Have you ever been in that situation, maybe with your own medication or someone you know's, where you hear about two different drugs for the exact same condition, and maybe one gets called stronger, another more effective, and you're left wondering, well, are those the same thing? Is stronger always, better? It's actually a really subtle but fundamental question in medicine, and honestly, it confuses a lot of people, sometimes even healthcare folks. So today, we're not just listing definitions. We want to crack the code behind how medicines really perform. We're diving deep into two core concepts: efficacy versus potency. And look, these aren't just dry academic terms. They're absolutely vital for understanding what a drug can truly do, what its limits are, and critically, how it's actually going to help you. Getting these two straight, it can be a real game changer in how you think about treatments.
Yeah, we got some really great material for this deep dive today. Some fascinating case studies, the kind you see in medical training, plus super clear definitions, and actually some clever analogies that should help cut through the complexity.
Our mission here is to equip you with a precise understanding. What do these terms really mean? Why do they matter so much in the clinic? And what actually makes a drug effective versus potent? We'll look at how these things are measured and really what it all means in practice. Okay, so let's jump right in. Let's tackle the first piece of the puzzle, potency. When we talk about a drug's potency, what are we actually talking about? Essentially, it's about the amount of drug you need. The dose, you could say, needed to produce a specific effect. Let's paint a picture. Imagine a 35-year-old woman. She's dealing with generalized anxiety. Her doctor has her try two different benzodiazepines. That's a common class of anti-anxiety meds at different times, of course. Okay, so drug A. She only needs 2 milligrams to get a noticeable reduction in her anxiety. But drug B, to get that exact same level of anxiety relief, she needs a 20 milligram dose. Now, here's the interesting part. Both drugs, if you give enough, eventually reach the same maximum benefit. So what does that tell us?
Well, that scenario illustrates potency perfectly. Drug A is clearly much more potent than drug B, even though, as you said, both drugs ultimately achieve the same maximum anti-anxiety effect, meaning their efficacy is the same.
Yeah.
Drug A just needs a much smaller dose to get there.
Ah, okay.
It's really about dosage efficiency, you see, not its ultimate power. It's like asking how lightly you need to press the gas pedal to get moving.
Right, right. And if you're a visual person like me, thinking about those dose-response curves helps. The graph plotting dose against effect.
Yeah.
Potency is basically the left-right position on the x-axis, the dose axis. A more potent drug, its curve is shifted further left.
Yeah.
Because you need less drug for the effect.
Exactly. And one of the analogies we came across in our sources really nails this, I think. If efficacy is, say, how high the elevator can go, then potency is just which floor button you press to get it moving.
Oh, I like that.
It's about the dose required to start that journey, not the final destination.
That clicks instantly. Effort versus destination. Okay, perfect. Now let's flip the coin. Let's talk about efficacy. Efficacy, on the other hand, is all about the maximum effect a drug can produce. It doesn't matter how high the dose goes, it's the drug's ultimate ceiling, its top capability, the highest point it can reach for anyone. Let me give you another quick vignette. Picture a 55-year-old man. He's in a clinical trial for chronic pain. 2 different opioid pain relievers. Drug X. At its maximal dose, it reduces his pain scores by up to 70%. Pretty good. But drug Y, even when they push the dose to its maximum, only reduces his pain by 40%. Now here's the twist. Drug Y achieves its 40% effect at much lower doses than drug X needed to get started.
And that immediately raises the critical question for that patient, doesn't it? Which drug is actually better for his pain? In this case, drug X clearly has greater efficacy. Even though drug Y is more potent, it works at a lower dose. It simply cannot achieve the same level of maximum pain relief as drug X. So potency kind of becomes irrelevant here if the drug can't reach the level of relief the patient actually needs. That ultimate ceiling, the efficacy, matters more in this context.
Right. If the elevator only goes to the 4th floor, it doesn't matter how sensitive the button is if you need to get to the 7th.
Precisely.
So back to our dose-response curve visually. Efficacy is the height of that curve. The peak on the axis, the effect axis. A more efficacious drug, it just has a taller curve, reaches a higher maximum effect.
But sticking with our elevator analogy, efficacy is how high the elevator goes. It's the absolute highest floor it's capable of reaching, its potential.
Okay, so quick recap before we dig deeper. Potency. How much you need. Efficacy. How much it can do at its best. It's about the quality, the magnitude of the effect, not just the quantity of the dose needed. All right, now this is where it gets really, really interesting, connecting this to what it means in the clinic for, actual treatments. Our sources highlighted some really high yield points here that make it click.
Exactly. The real sort of aha moment comes when you realize efficacy dictates the drug's ultimate capability. How much pain relief can it possibly provide? How much can it lower blood pressure at its absolute best? Potency, on the other hand, just tells you how much drug you need for a specific effect or how strong a particular dose is. Think about it. A drug could be incredibly potent, need tiny doses, but still be a terrible choice if its maximum effect, its efficacy, isn't enough for the patient's needs.
That makes perfect sense. Or the flip side, maybe a less potent drug, one needing a higher dose, is actually safer because it gives you more room to adjust the dose?
Potentially, yes. It depends on the drug's therapeutic window.
Okay. And you mentioned a memory trick.
Ah, yes. The sources offered a good one. Efficacy, elevator height, how high. Potency, button sensitivity, how little pressure needed.
Simple but effective. I like it.
Let's make it even more concrete. Think about analgesics, pain relievers. It's a classic example. Morphine, generally speaking, has greater efficacy than codeine. That means morphine can tackle more severe pain. It has a higher ceiling for pain relief.
Okay.
However, fentanyl is vastly more potent than morphine.
Right. We hear about that a lot.
Yes, and what that means is you need a significantly smaller dose, micrograms versus milligrams of fentanyl, to achieve the same amount of pain relief you'd get from a standard dose of morphine. The key thing here is the maximal pain relief from fentanyl and morphine might actually be quite similar at their respective top doses. They might reach the same floor eventually.
Ah.
But fentanyl gets you there with far, far less drug.
Right.
Much more potent.
That's a fantastic illustration. Same potential destination, very different amounts needed to get there. So this also ties into how drugs interact with our body's receptors, right? You mentioned agonists earlier. How does efficacy fit in there?
Absolutely. An agonist is basically a drug that flips a switch, it activates a receptor to cause a biological response. And efficacy is crucial here. A full agonist generally has higher efficacy than a partial agonist, the full agonist. It pushes the system to its maximum possible response. It's the top floor.
Got it.
A partial agonist, though, it also flips the switch, but only part way. It might be very potent, meaning it binds easily at low doses,
Okay.
but it will never achieve the same full maximal effect as a full agonist, no matter how much you give. It just can't push the system that hard. Its ceiling is lower.
So we have a good handle now on what efficacy and potency are and why distinguishing them matters in practice. But you hinted earlier, these values aren't always set in stone, are they? What things in the body can actually change a drug's potency or its efficacy?
That's a really important point. The body isn't static, and drug responses aren't either. Let's talk potency first. Potency can be influenced by basically anything that changes how much active drug gets to the receptor or how strongly it binds when it arrives.
Okay, like how well the key fits the lock, that kind of thing.
Exactly. That's receptor affinity. How tightly does the drug bind to its target receptor? Generally, stronger binding means higher potency. Fentanyl, again, its incredibly high affinity for opioid receptors, is a big reason why it's so much more potent than morphine. Fewer molecules are needed to occupy the receptors and get an effect.
Makes sense. Stronger magnet, needs less effort. What else affects potency?
Another major factor is competitive antagonists. Remember antagonists? Drugs that block the receptor.
Right, they block the lock.
Well, competitive ones compete for the same binding site as the agonist, the drug we want to work. If a competitive antagonist is present, you simply need more of the original drug, a higher dose, to sort of elbow the antagonist out of the way and get the same effect. This reduces the original drug's potency. Think about giving a beta blocker like propranolol alongside epinephrine. Epinephrine's potency goes down because it has to compete harder for those beta receptors. But, and this is key, its maximum possible effect, its efficacy, usually stays the same. It can still reach the top floor, it just needs a higher dose button pushed.
Fascinating. So it doesn't change what the drug can do, just how much you need to make it happen.
Precisely. And then there's the whole journey the drug takes in the body. Pharmacokinetics, often summed up as ADME, absorption, distribution, metabolism, and excretion.
Right, how it gets in, moves around, breaks down, and gets out.
Yes. All these processes dictate how much active drug is actually present at the receptor site and for how long. For example, if a drug is poorly absorbed from the gut, less gets into the blood, so its potency is reduced. Or conversely, if its metabolism is slowed down, maybe by another drug or liver issues, it hangs around longer, potentially increasing its potency. More drug is available.
Got it. So, big picture for potency. Anything making you need more or less drug for the same effect is affecting potency. Now, what about efficacy? What changes that ultimate ceiling, the maximum effect?
Efficacy is a bit different. It's more about the drug's inherent ability to activate the receptor after it binds. The main factor is intrinsic activity. This is the drug's power to actually flip the switch to cause that biological response. Full agonists have high intrinsic activity, high efficacy. They fully activate. Partial agonists bind, maybe even tightly, but have lower intrinsic activity, lower efficacy. They only partially activate. And antagonists, they bind, often strongly, but have zero intrinsic activity, zero efficacy. They just block.
That difference between just binding and actually activating is fundamental. So antagonists, again, do they only affect potency?
Here's where another type comes in.
Yes.
While competitive antagonists mainly hit potency, non-competitive antagonists can actually reduce efficacy.
Awesome.
These often bind irreversibly or maybe to a different site on the receptor that changes its shape. The end result is they effectively take some receptors permanently out of commission or make them unactivatable. So even if you flood the system with the original drug, you can't reach the original maximum effect because there are fewer functioning receptors available. It lowers the ceiling.
Wow, that's a huge difference. Competitive just makes it harder. Non-competitive actually lowers the max potential.
Exactly. And one more factor for efficacy, the state of the body itself, pathophysiology or tissue response. Sometimes the target organ or tissue is just too damaged or altered to respond fully. Think severe end-stage heart failure. Certain drugs meant to strengthen the heart's contraction, like inotropes, might just be less effective. Not because the drug changed, but because the heart muscle itself can't respond like it used to. The machinery isn't capable of reaching the drug's theoretical maximum effect. Efficacy is limited by the body's condition. And this all loops back nicely to classifying drugs based on efficacy. Full agonists, partial agonists, and antagonists. It really all hinges on their ability to activate that receptor. So full agonist binds, produces the maximal response possible for that system, like morphine hitting the top floor for pain relief.
Sure.
Partial agonist binds, but only produces a submaximal response, even if every single receptor is occupied. Buprenorphine is the classic example for opioids. It binds very tightly, maybe even more tightly than morphine.
Right.
But it has lower intrinsic activity. It can't stimulate the opioid receptor as strongly, so its pain relief ceiling is lower than morphine's. High affinity, lower efficacy.
Okay, that makes sense.
High binding, lower activation. And finally, the antagonist binds, but zero intrinsic activity, zero efficacy. Its whole job is to block agonists. Naloxone, the opioid overdose reversal drug, is a pure antagonist. It kicks opioids off the receptor and then just sits there, preventing activation.
That's crystal clear. And you mentioned a clinical scenario, I think it was related to the USMLE, that really drives home the importance of understanding partial agonists.
Yes, it's a classic trap, but also has critical real-world implications. Imagine a patient who is dependent on heroin, which is a potent full agonist. Now, let's say you give them buprenorphine, or partial agonist. What happens? Buprenorphine has extremely high affinity for the mu-opioid receptor. It binds very tightly, even more tightly than heroin in many cases.
Okay, so it sticks better.
Right, so it can actually kick the heroin molecules off the receptors. It displaces the full agonist.
Ah, I see where this is going.
But because buprenorphine is only a partial agonist, it provides much less receptor stimulation than the heroin did. So you go from high stimulation heroin to suddenly much lower stimulation buprenorphine, even though the receptors are still occupied.
And that causes...
That sudden drop in overall receptor activation can precipitate acute, often severe, withdrawal symptoms.
Wow. So the drug that's technically less efficacious causes a major negative effect because it displaced the more efficacious one. That's powerful.
It's a perfect example of why just saying stronger or weaker isn't enough. Potency, affinity, and efficacy all play distinct, crucial roles, and why understanding that lower efficacy doesn't mean less clinical impact is vital.
Absolutely eye-opening. So wrapping this up, what's the big takeaway for you, the listener, navigating health decisions or just trying to understand medicine better?
I think it's realizing that understanding efficacy versus potency gives you a much sharper lens. You can appreciate the real science behind drug choices. It's not just about grabbing the strongest pill. It's about finding the right tool for the specific job, the right drug, at the right dose, to hit the right target effect for your situation. This knowledge really helps you understand the why behind treatment plans.
Couldn't agree more. And maybe a final thought to leave you with. Next time you hear about a medication, maybe a new one on the news or even one you take, try to think beyond just the dose. Ask yourself, what's its potency? Sure, but more importantly, what's its efficacy? What's its absolute maximum effect? And what might the implications of that ceiling be? for treatment success, for side effects, maybe even for cost or public health policy. Thinking about both potency and efficacy gives you a much richer, deeper understanding of the science behind healing. It lets you ask smarter questions and truly engage with the medicine.